Hey everybody, my name is Deanna Cheathem and I want to go over my case study with you guys. So let me share my screen with you. All right, so my topic was dangers of chronic dysphagia and malnutrition. First, I'm going to go over the literature review with you guys and talk about the primary disease and the secondary diseases that develop because of it, and then also evidence-based recommendations. Part 2, I'm going to talk about the patient that I followed and the nutrition care process I did for him. So the primary disease that I studied was silent aspiration dysphagia. And silent aspiration dysphagia is actually not a disease, it's actually a collection of symptoms. And so it unfortunately affects our elderly population predominantly. In fact, if you're 76 years of age or older, about 27% of them have some form of dysphagia. Unfortunately, if you have had a stroke, your risk increases to 30 to 65%. So that kind of leads into the etiology a little bit. The main reason that dysphagia develops is because of acute and chronic neurological diseases, such as strokes. It can also be brought on by muscle disorders or GI issues or disorders with the throat or any kind of cancer. And when it comes to the cancers, they're usually located either in the neck region, or it can also indirectly impact swallowing by being located in the brain. And what happens is the location of the tumor can affect the messaging center that tells your body's muscles when to swallow and how to do it safely. And here is a little bit of anatomy, but I'm about to show you how exactly it all goes down. So this is what should happen. And then I'm going to show you what's actually going on with someone with silent aspiration dysphagia. So as you can see in stage 1, our epiglottis right here is up in our resting position, and the blue arrow indicates our breath. So we're breathing in. So our trachea is open and we are receiving air into our lungs. So whenever we have food in our mouth, it's then called a bolus, and we go to swallow. The brain sends neurons to the muscles to communicate for the epiglottis to briefly cover our trachea and our windpipe and very quickly pause of us breathing for the bolus to go down the esophagus. And then, as soon as that happens safely, our epiglottis goes back up and we are able to breathe into our trachea again. Unfortunately, the issue happens with people with dysphagia is because of the stroke or the placement of the tumor or other disorder, our brain is not sending the right messages, and the epiglottis is not doing the job it's supposed to be doing by covering the trachea opening, causing the bolus to enter into our windpipe and into our lungs. So signs and symptoms for someone with normal dysphagia is coughing and choking and gagging. But unfortunately, silent aspiration dysphagia, it's very hard to diagnose, and it's often misdiagnosed because it requires a modified barium study or something that will show the physicians what's going on the inside. Because on the outside, we don't see it or hear it or notice it. It's exactly that, it's silent. The brain is also not sending the messages for your typical reflexes to cough things up. So your prognosis and treatment options, just like the physicians try to do with treating the underlying cause, you're going to also try to treat the underlying diseases that are developed secondary to it. So they can try to treat the basic diseases that caused it, like if it is a muscle disorder, but typically if it's for a stroke patient, they don't usually recover 100%. They can work with speech therapy, and they can try to teach them different techniques for them to swallow. And that includes like a chin tuck or turning their head a certain way or doing anything of that nature to really make you focus on swallowing. They also do different types of diets, like dysphagia diets, and that'll also make the viscosity of your food and drinks thicker, so you focus more on getting it down the right tube. So here's the little video I wanted to show you guys comparing a normal healthy person swallowing to someone with silent aspiration dysphagia. This is a thin liquid, and you can see that his epiglottis does its job, covers the trachea very briefly, and gets it down the right tube or pathway. And it's going to do another slow-mo so you can really see what's happening with him here. This is the guy with silent aspiration dysphagia. So here it is, slow motion. And as you can see, it starts to collect on top of the epiglottis. And then it goes off of it, and then half of it goes down the esophagus, and the other half is trapped into the trachea, and it makes its way down into the lungs. And you can also see that he's not reacting. He's not coughing or doing any kind of external sign to try to clear it out of his trachea. So chronic dysphagia, specifically silent dysphagia, can lead to secondary diseases. And the two most prominent ones are malnutrition and aspiration pneumonia. Malnutrition is related to the prolonged inadequate oral intake, and this is just because you're going to choose to breathe before you're going to eat. And a lot of people just don't feel safe, especially stroke patients. They lose that basic function, and they can be scared to ask for help. They feel like a bother, and they're just scared that they're going to choke. And so they're the most likely to be at risk for higher amounts of malnutrition. Same thing with aspiration pneumonia. Because they're ingesting and inhaling those food particles into their lungs, the food particles gather, and then bacteria starts to form, and then it accumulates fluid, and it's just not a good situation. So this usually requires hospitalization. It increases your nutrient needs, which adds to the catch-22 because you're already at increased needs and you still can't get it orally safely, and now you need even more to help recover from this secondary disease. And so with that, it causes a higher rate of reoccurrence. And it happens a lot for people with dysphagia. So there was no dysphagia recommendation nutrient exact formula out there. And so I decided to go and aim for the underlying issues that my patient was dealing with at the moment. And so he had cancer. He was eventually put on a PEG tube, and he was very malnourished. So I focused on people who was elderly stroke patients that were post-chemo or on chemotherapy, so basically just cancer recommendations, and focused on meeting those needs because that would help the underlying and secondary issues that he's dealing with, including malnutrition. So for energy, I did 30 to 40 kcals per kilogram. Protein was elevated as well with 1.2 to 1.5. Carbs and fluids, there was nothing specific, so I did a basic diet. And then I included fiber just because, like I said, he had a PEG tube placed, and we did intro formula. And that can often be an issue, not getting enough fiber, because it can lead to loose stools or diarrhea associated with the tube feed. So I threw that in there just because we're going to be looking at that a little bit later on. So this is my patient, GW. He's a very sweet 92-year-old Caucasian Navy and Air Force veteran who resides at the Armed Forces Retirement Home. He has limited mobility, and it is honestly because he is so weak that he can't get up and walk and travel on his own. So he uses a rollator. And he also has an electronic wheelchair too. So he has a very complex medical history. Over the past couple years, he has been admitted to the hospital at least 5 times just with silent aspiration pneumonia. And so it just kept reoccurring. And they do believe that the whole onset of the silent aspiration dysphagia was because of a stroke that he had a few years ago. So he also is dealing with CKD stage 3, kidney and prostate cancer. The kidney has kind of calmed down a little bit. They were able to get reins on it, but the prostate, they're not even trying to treat. It's one of the prostate cancers that develops so slowly that it's just not something that they're too concerned about right now. He also has some cardiac issues with CAD, CHF, and hypertension. So he was 6 feet tall. He's always been a tall, slender gentleman. And the baseline data that I was able to gather showed that he was about 160 pounds in March. Then whenever I met him, he was 137. This is 22 and a half of unplanned weight loss, which is 14%, very severe. And like I said, he has a small frame size, and his BMI was 18.3, which is underweight. Now, when I did my follow-up, he was 136, and I'll go a little bit more into about what happened and everything in a minute. So here's what he was on when I met him. He was ordered Jevity, like I said, he had his PEG tube placed in July 31st. And so he was ordered Jevity 1.2, 7 cartons a day, and this should have met his needs. He was having a lot of trouble tolerating it. He was only getting 4 to 4.5 cartons, which was only providing about 1,200 calories. And it was not giving him what he needed at all. So here's Also, all the medications, you can also see that a lot of them had to do with either heartburn or loose stools. And he had a lot of, that was the issue with him not tolerating it. He kept describing pressure and just discomfort in his stomach and his esophagus after he, I think he said it was about 11 or 12 in the middle of the day when he started to feel uncomfortable and he just wasn't able to take in anymore. Here's a list of his previous diets in the past year. So in March, he was readmitted into the hospital because he had an exacerbation of his CHF. And he actually had a speech therapist look at him, and she said he was okay. And they put him on cardiac diet. So then he went back home to the Armed Forces Retirement Home and was on a regular diet. He was readmitted again into the hospital for another case of silent aspiration pneumonia. And this time they saw that he had an issue with swallowing finally, and they prescribed him a dysphagia diet. And then he finally got fed up with everything. The daughter and the physicians recommended PEG tube placement, and that happened July 31st. So here you can see where we switched to Gevity 1.2. It was originally 6 cartons, but for some reason, I guess they didn't think it met his needs. They moved it up to 7 cartons a day. But I wasn't changing the fact that he was only tolerating about 4. So he really was not meeting what he needed. So as I'm about to show you, my intervention was to change the formula. And then that happened. But while I left him to do that, he was readmitted into the hospital for some more complications with his CHF. And unfortunately, the speech pathologist there at the hospital did a bedside swallow study, and she said that he was okay to have a full liquid diet. So his tube feeding was not running at all. And that was very frustrating, especially because you can't see the signs and the actual function of silent dysphagia at bedside. And so he went down a little bit in his weight, and then when he got back home on the 17th of October, we got him back on the 2-cal. So I did categorize him as malnourished, severely malnourished. And I did this by collectively combining his anthropometric data, his lab data, and just his physical exam. So as you can see, he had a BMI of 18.3. He had the unplanned weight loss. I also used the Aspen, SGA, and NNA scores, and they all ranked him as severely malnourished. And then on his physical exam, I also saw severe muscle and fat wasting around his temple, clavicle, scapula, arms. And when he lifted to show me his PEG tube, you could really see his ribs. It was very prominent. So here's a track of, or trend, I should say, of his weights. You can see that in March, he was up in about the 160 range, and that's really what he's used to and what his goal weight is. And so, unfortunately, when I met him, he was not at that. And you can see where the green line is. That was my intervention. And it dips down just a little bit, and I do believe that was associated with the hospital visit where he was prescribed a full liquid diet, and he was not consuming near enough of it because he was scared. And then you can see how we leveled off right here because he went back home, and we were able to get a little bit of weight increase, which is a really good sign because this whole entire trend is him going down, and we finally stabilized and went back up. Here's his protein lab values, and I focused on this because this is just something that I look at for malnutrition. And you can see that we're going down, and then whenever I do my intervention, we go up just a little bit, but hey, we're going up. And I like to believe that this is because my intervention was providing 107% of energy needs and 100% of his protein needs. Now, I did his renal lab trends just because he was CKD stage 3. And a lot of research shows that we need to limit the protein intake. But I sat there and thought about it, and just my nutrition opinion, I think our malnutrition state trumps CKD right now. And so it's not something I'm just going to say, hey, forget it. I still monitored it, but I did believe that we need to get more protein in, and that was our main goal other than maintaining CKD. So I still tracked it. His average GFR is 36.25. So he still is in stage 3. So even though we amped up that protein to help with the malnutrition, it didn't affect his kidney status. So I'm okay with continuing that until we can get to our goal weight of 160 to 170. So here's my calculations. I definitely think that this will help him get where he needs to be. He needs about 1,800 calories a day, 80 grams of protein. And here's that 30 to 40 grams of fiber I was talking about. The fluid matches the calories. And as far as weight gain, I really am not worried about immediate weight gain. I'm more worried about maintaining what we have. And then once we have a good maintenance of where we're at, then we need to start gaining 1 to 2 pounds a week safely. So I diagnosed him with inadequate enteral nutrition infusion because he was not meeting the prescribed amount, unintended weight loss, and malnutrition. And all of this is evidenced by everything I just went over. We have the report of him only consuming 4 cartons when he's prescribed 7. We have the unintentional weight loss that's reported from March to now, and it was 14% and over the 8 months and 12% over the past 6 months. And so malnutrition is supported by all of that. We can look at the BMI, the physical exam, the albumin status, and just all of that together paints the picture of malnutrition. So here's what I wanted to do for Mr. GW. I wanted to do 2 cal, and I jumped the gun. I went over the Jevity 1.5, and usually it's best to go to Jevity 1.5, but I need to pull in the big guns for this gentleman. He's fallen through the cracks too many times. He's not improving. He's declining. Let's get everything we can for him. So altogether, I wanted to also provide Benefiber to help meet that goal for 30 to 40 grams a day, especially because one of his main complaints was loose stools. He was having a big issue with that. And then all that together, we're going to meet 100% of his protein needs, 107 of his energy needs, 107%, and then 110% of his fiber needs. I also threw this in there just thinking about how this could affect someone mentally. I think he does need to work with some of the social workers that are at the Armed Forces Retirement Home, and they're a part of his care. They see him quarterly anyway, so I really think that he needs to meet with him once or twice a month and really talk about just the big changes he's going through. To go from an oral diet to a peg tube, he was very positive and smiling, but I know that it can be hard. So I think he needs to meet with them and create a set of goals with them as well. So I'm going to monitor his weight, hopefully one day weight gain. His enteral nutrition and Benefiber infusion, is it matching what we have prescribed? His albumin lab values and physical signs of malnutrition. I understand that next time I see him, he's not going to be plump and filling out, but I don't want to see any more wasting. I want it to at least stay where it's at, and then we can improve it. And I also want to see that he is attending his counseling sessions with the social worker. So when I did get to see him again with my follow-up on 11/13, he was 136 pounds. So I know we went down 1 pound from the 137 when I met him, but he had actually fallen down to 132 during that hospital stay where they prescribed him the wrong diet. So we went from 137 down to 132 and then back to 136. So it seems like such a small achievement, but I really think we're going the right track. It's the first time that we have actually leveled off and seen a slight increase for him. So I'm really glad that we did that. And I think if we continue with our infusion rate, because he was meeting that 100%, tolerating it perfectly fine, his bowel movements actually improved. He was having 3 to 4 loose bowel movements a day, and now we're having 2 to 3, and they're more firm. So we're obviously on the right track. His albumin lab values were actually within normal limits where they were lower before. And so slowly but surely, we're starting to see a good trend. The patient GW, as I said, he's a wonderful, sweet, retired United States veteran, and he deserves the best care that we can give him. And he suffers from silent aspiration dysphagia, and that has led to recurrent aspiration pneumonia sessions in the hospital that he had to get treated for. So then we also have malnutrition, and that this is due to the chronic disease that he's been dealing with. And so I would like to predict that my nutrition intervention will be a success. It was already kind of a miniature success, but I would like to predict that it'll continue to help him improve with health and his malnutrition state overall. Here are my references. And if you have any questions, please feel free to email me or message me or do whatever you need to do. I really enjoyed working with him. He's a very sweet old man, and he has such a positive attitude, and he really is doing his best to improve. Thank you.